So we have with us Dr. Praveen Kumar, NS, Assistant Professor, Department of Endocrinology, MMC. There's many more to tell. He's the 5th rank in RGHS. He has got so many publications. I think that slide went off.
No problem.
Could you just show the previous slide? So he has 12 national and international journal publications. He is a contributing author in 3 textbooks. 5th rank in MD General Medicine in RGHS. His areas of interest is obesity, type 1 diabetes and young onset diabetes. Over to you, sir.
Thank you ma'am for that kind introduction. Surgery for anybody, like we have felt that how it feels like when our loved ones are on the surgical table, it's an emotion. Normally we would go to the temple and pray that things should be turning out better. From doctor's perspective is the same wish that our patient should be safe at the outcome of the surgery. So from a surgical perspective, it's a different thing because surgeon also needs to deal with complications or the medical legal aspects which are concerning today, for which the preparation of the patient is utmost important. From endocrine perspective, we have various conditions like diabetes or thyroid and adrenal which have its influence on its peri-operative outcomes. So today, for excluding diabetes, we are looking into the other endocrine conditions that would be influencing the outcomes, because endocrine disorders might impact the electrolytes, cardiovascular functions, as well as the outcome. So this would be my outline. I will be going with the introduction, and I will be approaching this presentation with a case-based discussion, primarily involving the thyroid and adrenal, and the approach would be based on the guideline currently what we have, and we'll have some conclusions with it. So as I mentioned, endocrine organs are key regulators of metabolism, fluid balance, CV function and stress response. So from moving to a thyroid case, a 56-year-old female referred to me by an obstetrician for prolapsed uterus. She was planned for surgery. Her weight is 65 kilos. On routine evaluation, it was found to be 34 millinternational units per ml. She was planned for elective surgery. So what should be the choosing time? When would you like to be doing the right intervention? So I will discuss later, but I want to project another scenario where T3 is normal, T4 is normal and TSH is mildly elevated. Let's assume it is 8. Can we clear the person for the procedure? Now, 38-year-old female, P2L2, recent onset of irregular menses, found to have fibroid. She was planned for hysterectomy. Her T3 was normal, T4 was low, TSH was 7.25 millinternationals per ml. Can we clear the person for the procedure? So that I just want to highlight, I will come back to this case, the first one, but here certainly we can clear the case, because in this case total T3, T4 are normal and free hormones were normal with mild elevated subclinical range. This patient is safe to go for a procedure, but not here. It appears to be simple with low T4, and when she was done with free T4 it was lower. We done a parallel cortisol that turned out to be lower, and it would have been proven very difficult procedure unless otherwise we picked up. So we cannot clear this person for surgery. She required further workup to rule out any pituitary, and with a previous history of meningitis she appeared to have going for hypopituitarism. It was a case of central hypothyroidism. Now going to the management, what we practice is based upon the ATA guidelines, which emphasize that achieving a euthyroid state is essential for optimal surgical fitness in patients with hypothyroidism. So pre-operatively, whenever we see a case, we need to ask about any previous history of any thyroid illness, any medication intake, previously discontinued or currently ongoing. On clinical examination, we have history of suspicion of hypo or hyperthyroid or beta goiter. Probably they need to undergo a thyroid function test for sure. So surgical risk stratification is based upon the kind of procedure. Is it a minor procedure, let's say a dental extraction or a surgery like which can be proceed ahead even with a mild or subclinical hypothyroidism because of normal T3 and T4. For example, a cataract extraction does not require the correction actually. Even subclinical we can definitely give the clearance. But whereas moderate to severe to overt hypothyroidism, especially if symptomatic, elective surgery should be deferred until the patient is adequately treated and euthyroid. From in our side, like what we say, even with a subclinical hypothyroid, if not corrected, something goes wrong with the surgery, then it will be blamed upon the physician. So it's wise and to go with sticking to the guideline that any patient with overt hypothyroidism needs to be optimally corrected and then only surgery should be proceed. So the idea is euthyroidism, levothyroxine is the standard therapy, IV preparations are hardly used, exceptional cases of myxedema coma. Now coming to the another case, I work in Mysore Medical College where I work like it's adjacent to Jaideva. I get few references from there as well. So it's a 57-year-old male who presented with NYHA class 3 dyspnea on exertion. TMT was positive, in CAG showed triple well disease and he was planned for CABG. On this routine evaluation, it was found to have elevated TSH of 68. What would be the next step? Should we stick to the guideline? Let's postpone the surgery, go ahead, or should we go ahead with the surgery? So, there were studies that were done in the past where the patient was not even diagnosed with a case of hypothyroidism, but they went ahead with the surgeries. So, many of these patients' outcomes were known and studied, and it showed that such patients were having not many of the complications. So these findings also relevant to the treatment of hypothyroid individuals with symptomatic coronary artery disease. So that means to say, in case of emergency or an urgency, we can certainly give fitness for these patients, and it is safe to proceed with coronary intervention with no significant rise in perioperative cardiac risk and restitution to euthyroid state not mandatory before surgery if urgent. So, but having said that, one should stay alert, look for the complications. We should give a guarded fitness with looking for monitoring for carbon dioxide retention during the procedure, delayed anesthesia recovery. There could be possibility of post-operative ileus, excess bleeding because of acquired von Willebrand factor deficiency, poor fever response to underlying major infection, poor wound healing needs to be explained, rarely hypothermia, hyponatremia again is very rare, but still that needs to be mentioned. Myxedema coma is a rare but life-threatening surgery should be postponed whenever possible. If unavoidable, IV thyroid preparation and empiric glucocorticoid therapy are recommended. Switching from hypothyroidism to moving to a hyperthyroid, this is one of the case from surgical reference where 54-year-old male with pain abdomen, evaluation suggestive of cholecystitis, and routine evaluation with retrospective history was suggestive of hyperthyroidism. His T3 was 671, T4 20, TSH was suppressed. What's your next move? Now I will put up some of the scenarios where hyperthyroidism would be clinically presenting. It would be a newly diagnosed finding in a case where normal T3, normal T4 and low TSH would be there, the diagnosis of subclinical hyperthyroidism. Or a case scenario where the patient was previously diagnosed with hyperthyroidism on medication, but again your T3, T4 being normal and suppressed TSH. Case scenario 3, which is a current scenario where patient is newly diagnosed with overt hyperthyroidism. 4, where previously diagnosed hyperthyroid on treatment and currently euthyroid, even normalization of TSH. So these are the 4 different clinical scenarios which we often see in our clinical practice. So going ahead with surgical risk, especially in thyrotoxic, it is observed that poorly controlled thyrotoxicosis has been associated with significant post-operative mortality. Deaths were largely due to storm because of its effect on the heart by vasodilatation, tachycardia, impact on systolic blood pressure, arrhythmia, angina and congestive heart failure. Beta blockers often control mild symptoms. Severe symptoms in these patients would certainly require ICU stay. So in a patient, when we are encountering hyperthyroidism and there are surgical risk approach, we need to go with thyroid status evaluation, diagnose is it overt, subclinical or euthyroid in the first place, have a detailed cardiovascular assessment for heart failure, rhythm and heart rate, and optimize the thyroid function using beta blockers and antithyroid medications. Methimazole or carbimazole are the preferred ones, And we need to look for additional comorbidities, all these patients in the approach, and then especially during the operative state, closely monitor on the heart cardiovascular parameters, making sure to avoid the thyroid storm. And it's an interdisciplinary approach to involve physician, surgeon as well as the anesthetist during this whole process. Now what matters is the timing. So it should match the surgical urgency and our endocrine remedies. Now when we call an elective surgery where we have enough sufficient time, like weeks together, we can evaluate and optimize therapy, prepare the patient for the best outcome. Urgent surgeries where we have few days, during that period we need to stabilize and then operate. Emergency surgeries, we have to go with rescue and then execute surgery. We have few hours to operate. Now for example, in an elective surgery should always be postponed until the patient has become clinically and biochemically euthyroid, to be achieved with antithyroid medication optimally and aggressively used, so that surgery is done on time, and this would give us better perioperative outcomes. In an urgent surgery, I am just going out with an algorithm of the regimen that can be used. We need to optimize the dose of antithyroid medication. We can go ahead with use of propranolol 40 mg thrice daily, or dexamethasone 4 mg TID or betamethasone of 0.5 mg 4 times. Sodium hypnoate or hypnoic acid 5 mg, 500 mg 6th hourly. With this regimen, compositely it acts on different mechanism. In the first, you can see it reduces the production of the new hormone. Second, when we use hypnoic acid, it actually causes reduction in the secretion of the hormone from the gland, and propranolol when used at a higher dose like 120 160 mg, it helps to prevent the peripheral conversion of T4 to T3 along with dexamethasone or betamethasone when used. So all this would keep the patient prepared, and we can proceed ahead with the surgery as on day 6. Suppose we need to give fitness on 1 or 2 day prior, like probably we can go with this regimen for at least 3+ and then proceed to the surgery. Coming to an emergency surgery, for the case that I discussed falls into the urgent care category, so the person falls into that scenario, where in case of an emergency surgery, immediately the patient needs to be given higher dose of methimazole. If you have few hours, go with 30 mg and repeat the dose. And after 1 hour, we need to give the Lugol's iodine 8 to 10 drops. If time is there, you can go ahead with TID, because in the first step, like we are blocking the synthesis, in the second step we are blocking the synthesis release of it. Third, again prevent the peripheral conversion by using beta blocker, and also it is important in such scenarios to keep the IV esmolol ready. And finally, to give steroids, hydrocortisone can be given 100 to 300 mg IV TI thrice daily, best of one scenario. Or else if we don't have any these possibilities, we can go still ahead with the surgery with a dialysis or a plasmapheresis, another option in such scenarios. So the goal of the therapy is ideally the thyrotoxic patient should be as close as possible to clinical and biochemical euthyroidism. TSH, in one of the cases I showed, remains suppressed as a consequence of prolonged hyperthyroidism despite normal T3. In such scenarios, one can definitely go ahead with the surgery. It's not a contraindication. And coming to the next case scenario, where we are dealing with a case of surgical fitness in a suspected patient who had taken chronic steroid, and what are the challenges that we see. Now in this patient with 56-year-old male, known case of psoriasis, probably has taken steroids. He met with an RTA, had a fracture, he scheduled surgery. Examination had Cushingoid feature, 8 cortisol showed suppressed, and he was referred for surgical fitness. The perioperative risk of this secondary adrenal insufficiency is well known, because it will fail to mount an adequate response during the procedure that will lead on to crisis, a life-threatening emergency, hypotension, shock, hyponatremia and glycemia. Now a pre-operative risk assessment needs to be done in such patients to go for a detailed drug history. The duration and dose are key here. Review for comorbidities and any signs of infection needs to be considered, and we need to look for glucose, electrolytes, renal and liver functions, and any correction of electrolytes and glucose needs to be addressed, and importantly rule out sepsis. Now this is the perioperative steroid policy. In patient at high risk of perioperative adrenal insufficiency, hydrocortisone replacement is done just at the induction of anesthesia with 100 mg. Hardly the patient with surgical risk requires nearly 200 milligram is the funda. Based upon that, like intraoperatively and post-operatively, hydrocortisone 50 milligram 8 to 6 hourly is given for major surgeries for 1 to 2 days. Subsequently, it is tapered down. Usually 50% is reduced from 50 milligrams 8 hourly to 25 milligram 8 hourly. Once they are shifted to the ward, we can switch them to oral prednisolone, and gradually the patient can be put on the basal oral prednisolone or oral hydrocortisone. Later, at the same time, parallel, the patient should be monitored for risk of adrenal crisis like hypotension, shock if they are unresponsive for fluids or vasopressor. Hyponatremia, hyperkalemia, hypoglycemia needs to be considered subsequently even after the discharge till they are completely okay. So when not to give steroids, we should know steroids patient has consumed for a shorter than 3 weeks, dose less than 5 milligram equivalent to prednisolone, or any procedures that are superficial like a biopsy, FNA or a cataract, the person need not be given the stress dose of steroids. Or when it is actually recommended without additional testing is when we have evidence of primary or secondary adrenal insufficiency, patient with clinical Cushing with history of steroid exposure like our case, a dose of more than 5 milligram more than 3 weeks in recent 3 months, and any patient on higher dose of inhalation steroids. So Endocrine Society latest guidelines suggest stress dose of steroids is indicated if adrenal suppression is suspected and cortisol is less than 5 micrograms per deciliter. And coming to the last scenario, which is very rare, having a Cushing's disease and then we have to give the fitness, there are certain aspects which we need to consider in this parameters. One is CV status, because they can be having uncontrolled hypertension. We need to assess their heart. ECG and echo needs to be done. Glucose control is important to optimize glucose control effectively. Electrolyte imbalance needs to be corrected, especially the potassium. Thromboembolic risk is very high. This patient needs to be started with DVT prophylaxis with low molecular weight heparin of 40 units, and early mobilization needs to be promoted in these patients. And infection prevention, we can start antibiotics in these patients. Preoperative medical, if we have got time, probably we can use agents to reduce the synthesis of this cortisol. It is a multidisciplinary care where coordinate the endocrinology, anesthesia, cardio, and finally high risk needs to be excluded, especially in these cases, to proceed with the fitness. So perioperative monitoring is utmost important in all the cases where volume status, cardiac function and stress dose preparedness needs to be done in case of deficiency, in case of inadequacy of the glucocorticoids during the process. So to conclude my presentation, surgical fitness is essentially for better post-operative outcome. Non-diabetic endocrine dysfunctions are common in our clinical practice. A detailed endocrine evaluation, medical optimization and multidisciplinary collaboration to reduce perioperative morbidity and ensure safe surgical outcomes. Vigilant perioperative monitoring and preparedness for endocrine emergencies and complications are very essential in our practice. With this, I would conclude my presentation and thank you.
Thank you, Dr. Praveen, for your very insightful talk. Any questions?
If any thyroid and liver thyroid is not available, in case of mixed hematoma or any severe hypothyroidism detected the first time, it goes for an emergency surgery. Overall, what should be the dosage?
So usually 400 to 600 micrograms through Riles tube. If it is mild, as I mentioned, subclinical 5 to 10, we can certainly go ahead with the surgery. Make sure you get a free T4. If it is more than that, since we have got time, better to correct and then proceed for surgery. Normalize.
Normalize T4 or TSH?
No sir, TSH. Better to normalize TSH. Anyway, we have got time. Anyway, it will get corrected in another 4 to 6 weeks. See, as I mentioned, TSH correction will take a longer course, even after correction of total T3, T4 and free T4. So in already a patient who is on antithyroid medication, he comes to you and during that phase, like his TSH is suppressed, patient is clinically euthyroid, biochemically his T3, T4 are normal, still he can go ahead with surgery. And in some patients we get a very narrow window. If we treat them, if we miss that time, like they will turn out to be hypo, because there are some people who are very aggressive. During that phase they can go for hyper and to hypo, even so alteration. So whenever in the right window, probably we need to go ahead with the procedure. Yes. So we have to weigh the risk of the current existing condition versus the complication that can arise out of the underlying condition. So based on that, probably it is well mentioned that complications are so uncommon and which is very much manageable during the perioperative phase. We should not delay the surgery in case of emergency, but to proceed and give the opportunity for the patient.